Usually, like when we talk about a medical diagnosis, there's this expectation of precision, right? It
Uh-huh.
feels like engineering. You break your arm, the x-ray shows that jagged white line, and the doctor just points at the screen and says, "There it is."
Right, there's the problem.
Yeah. It's comforting because it's visible.
I mean, a fractured bone is a clean, undeniable binary,
Yeah.
It is either broken or it is intact.
Exactly. But then you step into the world of mental health, specifically neurodevelopment and mood disorders, and suddenly that x-ray machine is, well, completely useless.
It really is. You're looking at a diagnostic landscape that is just incredibly murky.
Which is exactly why we're here. Welcome to today's deep dive. Our mission today is to unpack a really fascinating and honestly a deeply misunderstood topic for you.
It's one of those things that affects so many people, yet remains so hidden.
Right. We're utilizing a comprehensive look at a source titled Unmasking Bipolar II, Diagnostic Clarity and Therapeutic Support. And we're pairing that with practical clinical frameworks from a Georgia-based practice called Coping and Healing Counseling, or CHC.
And we're starting with a pretty staggering statistic today.
Yeah, we are. Because when looking at bipolar II disorder, the average delay for a patient to actually receive a correct diagnosis, it exceeds 10 years.
An entire decade. Just let that sink in.
10 years is a staggering amount of time.
It's a full decade of moving through the medical system. I mean, that means 10 years of seeing different doctors, sitting in waiting rooms, trying a revolving door of different treatments.
And still not having the correct label for what is fundamentally happening in your own brain.
Exactly. This isn't just a delay in paperwork. It's a decade of collateral damage to a person's life, their career, their relationships.
Okay, let's unpack this. How does a major mood disorder hide in plain sight for over a decade? Like, how does the entire medical community miss something so significant for so long?
That is the defining mystery we need to solve today. And for you listening, understanding this is incredibly crucial.
Because we live in an era of absolute information overload, right?
Oh, totally. Especially regarding mental health. I mean,
Yeah.
if you spend 5 minutes on social media, you will see clinical terms thrown around very casually.
Yeah, everybody's an expert online.
Right. So understanding the actual clinical nuances of mental health diagnostics helps us navigate that noise. It builds empathy and, well, it builds critical medical literacy.
Which we desperately need.
Absolutely.
Yeah.
And the answer to that 10-year mystery lies in the tricky disguise of the disorder itself. Bipolar II is like an absolute master of camouflage.
Let's talk about that camouflage, because bipolar II is actually the most commonly misdiagnosed mood disorder out there.
It really is.
It is most frequently mislabeled as treatment-resistant major depression, which, on a surface level, makes total sense.
Because of what the patient presents with.
Right. A patient goes to the doctor because they're feeling incredibly low. They can't get out of bed. The brain fog is immense, and so they get a depression diagnosis.
It seems like a very straightforward clinical picture.
But I was thinking about this dynamic. If someone is chronically depressed, heavily weighed down for months at a time, and suddenly they wake up and they are hyperproductive,
Yeah.
they are super social, they need way less sleep to function, I mean, they wouldn't think they're sick, would they?
Not at all.
It's kind of like driving a car that's been sputtering and stalling out for miles, barely making it up a hill, and suddenly the engine catches and it shoots up to 100 miles per hour.
That is such a good way to put it.
You don't sit there and think, oh no, the engine is broken in a new and dangerous way. You just grip the steering wheel and think, finally, it's working.
What's fascinating here is how accurately your car analogy captures the lived, internal, subjective experience of the patient.
Right, because they don't feel sick.
Exactly. In clinical terms, that period of driving 100 miles per hour is called hypomania. And for the patient experiencing it, hypomania literally feels like finally feeling normal.
Or even better than normal.
Yes, in many cases, feeling better than normal. It's characterized by high productivity, intense sociability, and this profound sense of capability that was completely absent during the depressive phase.
Like the heavy blanket has just been lifted off of them.
Precisely.
Because to you, that just feels like you're finally winning at life. You are finally the person you always thought you could be if you just weren't so depressed all the time.
Which is exactly why no one goes to the doctor to complain about it.
Wait, yeah, that makes perfect sense.
Think about the fundamental mechanics of a doctor's visit. You make an appointment when you are in pain, when you are suffering, or when you're immobilized by depression.
Right, you don't go when you're feeling awesome.
Exactly. When you are the life of the party, getting 3 hours of sleep and finishing a month's worth of spreadsheets or creative projects in a single weekend, You do not call your psychiatrist to report a problem.
You're just living your best life.
The ultimate disguise of bipolar II is that its defining feature, the hypomania, masquerades as the cure to the depression. The symptom hides itself by pretending to be the solution.
Wow. But since hypomania feels like feeling normal to the person experiencing it, the burden falls entirely on the clinician, doesn't it?
It really does. It's a huge investigative burden.
How does a doctor, someone sitting on the outside of this experience, seeing a patient for maybe 20 minutes every few months, actually spot the difference between someone just having a really great productive week and someone experiencing a clinical episode of hypomania?
That is where the specific diagnostic criteria become the vital map for clinicians. It's not just about having a good week or finally getting organized.
Right, there has to be a benchmark.
Exactly. The clinical definition requires a very specific, observable pattern. First, it must be a pattern that alternates with major depression.
Okay.
Second, the hypomanic phase must last for at least 4 consecutive days.
4 days of continuous elevated output. That's a lot.
And during those 4 days, the clinician is looking for an elevated or sometimes highly irritable mood.
Irritable. Really?
Yes, people often associate mania with happiness, but it can just as easily manifest as severe impatience or irritability, because everyone else seems to be moving way too slow.
Oh, that makes sense. Like they're stuck in traffic and everyone else is just in their way.
Exactly, but here is the major clinical distinction from just having a busy schedule. It involves a decreased need for sleep entirely without feeling tired.
Okay, that distinction is huge.
It's the hallmark symptom.
Because, like, if I pull an all-nighter to finish a project, I might be productive for a minute, but the next day, I'm a zombie. I am physically exhausted. My body demands the sleep back.
Right, the sleep debt catches up to you. But a person in a hypomanic episode bypasses that exhaustion. They might sleep for 2 hours, or not at all, and wake up feeling entirely refreshed.
Just buzzing with physical energy.
Yes. Along with that, you see racing thoughts. Imagine a web browser with 100 tabs open, and they're all playing different audio, but the person somehow feels like they can listen to all of them at once.
That sounds overwhelming.
It is. And combined with that is a massive increase in goal-directed activity.
But driving a sputtering car at 100 miles per hour isn't just a relief, it's incredibly dangerous. You're eventually going to crash.
You are. The engine isn't built for it.
It's not just about aggressively cleaning your house or finishing work projects, right? There is a much darker side to hypomania involving serious risk-taking behaviors.
Yes, the risk-taking is the destructive edge of the sword.
We're talking about making massive, life-altering plans out of nowhere, quitting jobs on a whim, or engaging in huge, impulsive spending sprees.
And it often has devastating consequences for the person's life, their finances, and their relationships.
I can imagine.
But there is another massive red flag, a specifically medical one that clinicians have to watch for. It happens when patients are stuck in that misdiagnosis of major depression and are prescribed standard antidepressants.
Like SSRIs and things like that.
Exactly.
Wait, I want to jump in here and ask a genuine question about that. Because if antidepressants are literally designed to lift you out of the dark, wouldn't a doctor want the medicine to work really well?
That's the logical assumption, yes.
If a patient takes an antidepressant and suddenly they have all this energy and they feel fantastic, how do clinicians distinguish between the medicine simply working as intended versus a fundamentally incorrect diagnosis of major depression?
It comes down to understanding the neurobiological landscape we're dealing with. The goal of an antidepressant for major depression is to return the patient to euthymia.
Euthymia, okay.
Which is the clinical term for a normal, stable baseline mood.
Yeah.
It lifts the heavy fog. But an antidepressant shouldn't make you stop needing sleep entirely.
Right.
It shouldn't make your thoughts race so fast you can't speak them. And it certainly shouldn't compel you to empty your life savings to start a new business you just thought of 3 hours ago.
Which shouldn't turn you into a superhero.
Precisely.
Yeah.
If the medication pushes the patient past baseline stability and into hyperarousal and risk-taking, the medication isn't just working too well.
What is it doing then?
It is acting as an uncontrolled accelerant. In a unipolar depressed brain, an antidepressant helps restore balance. But a bipolar brain responds differently.
Oh, wow.
If you give a standard antidepressant to someone with bipolar II without any other protections, it can actually act as the biological trigger that launches them directly into a hypomanic episode.
It's like pressing the gas pedal to the floor in a car that has no brakes installed.
That is exactly what it's like.
Okay, that changes the entire paradigm. It's not just a matter of the mood lifting, it's the speed limit of the brain being completely shattered.
Right.
So what does this all mean when a clinician finally catches on, when they see the antidepressant causing this hyperarousal, and they realize they've been dealing with bipolar II for the last decade instead of unipolar depression?
Well, getting the right diagnosis can't just be about changing the label on an insurance chart.
It has to be more than that.
It requires a complete teardown of the existing treatment plan. It is a fundamental pivot. When the diagnosis shifts from major depression to bipolar II, the standard protocol shifts aggressively away from using solo antidepressants.
To what instead?
The cornerstone of pharmaceutical treatment becomes mood stabilizers.
Okay, let's talk about the mechanics of a mood stabilizer, because the name itself sounds very, I don't know, generic.
It does, yeah.
How does a mood stabilizer actually differ from an antidepressant in the brain?
If an antidepressant is the gas pedal trying to get a stalled car moving, a mood stabilizer acts like a governor on an engine.
A governor, like the mechanical part.
Yes, a governor is a device that physically limits how fast an engine can spin, preventing it from tearing itself apart. A mood stabilizer sets a neurobiological floor and a ceiling.
Okay, so it stops the extremes.
Exactly. It prevents the depressive drops from going too low, but just as importantly, it puts a hard biological ceiling on the mood to prevent the brain from escalating into the hyperarousal of hypomania. It provides the brakes.
But medication is only half of the equation to finding actual steadiness, isn't it? The text emphasizes that these mood stabilizers need to be combined with highly specific therapies.
Yes, medication alone usually isn't enough.
And the one that really stands out is IPSRT, which stands for Interpersonal and Social Rhythm Therapy.
That's one. Or specialized CBT adapted for bipolar. But IPSRT is a brilliant approach because it targets the very specific biological vulnerabilities of the bipolar brain.
How does it do that?
The core philosophy of IPSRT is that our daily routines, our circadian rhythms, our sleep and wake times, our meal times, our social interactions are directly tied to our mood regulation.
Okay, so routine is everything.
For someone with bipolar II, a disruption in their daily rhythm isn't just an inconvenience. It can be a clinical trigger.
So we aren't just talking about feeling a little groggy the day after a late night.
Not at all. Let's look at a concrete hypothetical scenario. Imagine a patient who has been relatively stable, goes to a concert.
Sounds fun.
Right. They stay out until 3 a.m., they sleep for maybe 3 hours, and then they force themselves up to go to work the next day.
Ugh.
For a neurotypical brain, that results in a miserable, exhausting Tuesday.
Lots of coffee needed.
Exactly. But for a brain with bipolar II, that shattered sleep cycle sends a signal of intense biological stress. The brain might respond to that lack of sleep by flooding the system with dopamine and norepinephrine to keep the person awake.
Oh, wow. So the brain overcompensates.
Yes. Suddenly, the patient isn't tired at all. They are buzzing, they are talking fast, they are hypomanic, all triggered by one night of disrupted routine.
And so IPSRT is designed to build architectural guardrails around that routine to prevent the trigger from ever being pulled.
That's it entirely.
It teaches the patient how to meticulously protect their sleep hygiene, their eating schedule, and even their social stimulation.
Yes, to maintain that equilibrium.
But getting to the point where a patient is utilizing mood stabilizers and charting their social rhythms in IPSRT, that starts with what clinicians call an honest evaluation.
And that evaluation process is incredibly rigorous.
Because it includes specific mood disorder questionnaires, but it also relies heavily on something called collateral history.
Collateral history is the mechanism that pierces the camouflage of the disorder.
Because you can't just trust the patient's perspective.
Right. This means the clinician isn't just relying on the patient's self-reporting. With the patient's permission, the clinician is speaking to their family, their spouse, or their closest friends.
Because of the subjective experience we talked about earlier, the patient doesn't remember a manic episode. They just remember having a really great, highly productive summer where they felt amazing.
Exactly. But the spouse remembers the reality.
Yeah.
The spouse remembers the massive, unexpected credit card debt. They remember the nights the patient paced the house until 4 a.m. talking a mile a minute. They remember the extreme irritability when anyone tried to slow them down.
So the external view is completely different.
The patient's internal narrative might be, I was finally cured. But the external collateral history reveals the hypomania.
Wow.
If we connect this to the bigger picture, this entire pivot in treatment underscores a fundamental truth about mental health. Accurate knowledge, applied correctly, is the only way to find actual steadiness.
Without it, you're just guessing.
Misdiagnosis traps people in a cycle of failing treatments, but the right evaluation opens the door to genuine stability.
Here's where it gets really interesting, though. Knowing the clinical criteria, understanding how mood stabilizers act as a governor on the engine, mapping out social rhythms with IPSRT.
Yeah.
All of that incredible science is purely academic. If a patient cannot actually access a licensed clinician to perform that honest evaluation in the first place.
You hit the nail on the head.
You can know exactly how to fix the engine, but if you can't get it into the shop, you are still stuck in that 10-year delay.
The logistics of access are, quite frankly, the single biggest barrier to mental health care today.
Totally.
And that brings us to the practical solutions outlined in our research regarding coping and healing counseling.
Coping and Healing Counseling, or CHC. This is a therapy practice serving all 159 counties in the state of Georgia.
Every single one.
Think about a state as large and diverse as Georgia. You have sprawling, deeply rural areas where the nearest psychiatric specialist might be a 3-hour drive away.
And then you have heavily congested urban centers like Atlanta, where a 20-mile drive could take 2 hours in traffic.
Right. So CHC essentially obliterates both the geographical and the logistical barriers to getting that life-changing diagnosis, because their entire model is built on telehealth.
Which is such a game changer. By utilizing a fully HIPAA compliant telehealth infrastructure, the evaluation doesn't require a patient to take a full day off work to travel to a clinic.
The evaluation happens securely in their own living room.
Exactly. And the infrastructure supporting this is robust. I mean, CHC operates with a team of over 15 licensed therapists.
And we're talking clinical social workers, professional counselors, and marriage and family therapists.
Licensed professionals across the board.
And it is vital to point out that they emphasize having a diverse, culturally competent team.
That is so important.
Because when you are asking a patient to undergo an honest evaluation, and you're asking them to bring in their spouse for collateral history to discuss very vulnerable, sometimes destructive behaviors.
You need to feel deeply understood by the person on the other side of the screen. Cultural context matters immensely in how we communicate our mental states.
It changes everything.
It dictates the trust level of the entire therapeutic relationship. And because they have this diverse clinical team, they cover a very comprehensive umbrella of care.
They evaluate for complex mood disorders like bipolar II, but their broader specialties are extensive too. Anxiety, depression, trauma, and PTSD.
Yeah, and grief counseling, relationship issues, and general stress management.
Plus, they offer individual therapy, couples therapy, family therapy, and even teen therapy for kids 13 and up, and life coaching.
It's a very holistic approach.
But we have to address the other massive wall blocking people from care. We solved the geography problem with telehealth, but what about the financial problem?
The cost is usually the deal breaker.
The cost of specialized therapy is often what keeps people trapped in the cycle of misdiagnosis. They just stick with their general practitioner prescribing SSRIs because they literally can't afford a specialist.
But CHC's financial model is incredibly disruptive to that barrier.
It really is. For patients on Medicaid, there is a $0 copay.
Think about the impact of that. $0 to sit down with a licensed specialist and finally figure out what is going on.
It's life-saving. And for those utilizing private insurance, the accessibility remains remarkably high.
They accept major providers like Aetna, Cigna, Blue Cross Blue Shield, United Healthcare, and Humana.
And the out-of-pocket sessions generally range from just $10 to $40 a session.
That combination telehealth, reaching every county, and financial structures that remove the paralyzing cost of entry, it radically alters the landscape for someone who has been lost in the medical system for a decade.
It provides an actual realistic off-ramp from the medication merry-go-round.
It really does.
So for you listening, if anything we've discussed today resonates with you, or maybe makes you think of a loved one who has been struggling with cycles of depression and sudden, unexplained bursts of risky hyperproductivity,
We want to make sure you have the concrete resources to take the next step.
you can explore their team and services online at cheektherapy.com. You can reach out directly via email at support@cheektherapy.com, or you can call their office at 404-832-0102.
I do want to reiterate one vital safeguard before we conclude, though.
Of course.
While we have spent this time outlining the specific clinical criteria and the biological mechanisms of bipolar II, a diagnosis must always be made by a licensed clinician.
Always. You can't just diagnose yourself off a podcast. I mean, a deep dive.
Exactly. Reading about hypomania or recognizing your own disrupted sleep patterns is a fantastic starting point for curiosity. It builds your medical literacy. But the professional licensed evaluation is the key that actually unlocks the proper customized treatment plan.
You absolutely want the expert looking at the map before you rebuild the engine.
I said.
So for you, taking all this in, let's look at the incredible journey we've taken today. We started with that devastating statistic, a 10-year diagnostic delay for a major mood disorder.
10 years of hiding in plain sight.
We uncovered the reason for that delay. The incredibly tricky camouflage of hypomania, where the primary symptom of the disorder feels subjectively like finally feeling normal.
The hardest disguise to spot.
We explored the massive biological pivot required when a correct diagnosis is made, shifting away from antidepressants that act as accelerants to mood stabilizers that act as governors.
And utilizing highly specific structural therapies like IPSRT.
And finally, we looked at how modern telehealth models, specifically CHC in Georgia, are actively breaking down the geographical and financial walls to make those life-changing evaluations accessible to everyone.
This raises an important question, though. We've spent this entire deep dive dissecting how a mood disorder operates, how it masks itself in productivity and energy, and how clinicians must work to uncover the truth hidden beneath the symptoms.
Right.
But it requires us to turn that analytical lens inward, just a little bit.
It really does, because when you think about it, if our own internal perception of finally feeling normal or feeling the best I ever have can actually be the primary destructive symptom of a deeply misunderstood disorder,
Yeah.
how well do any of us truly know our own baseline? How much can we trust our internal narrator without the honest, outside perspective of someone trained to look for the patterns we just can't see in ourselves?
That is something to think about.
Thank you so much for joining us on this deep dive today. Keep asking questions, keep looking for the patterns, and keep seeking clarity. Until next time.